Hi, everyone. Welcome. We'll give it about a minute just to allow everyone to hop on before we go ahead and get started. Hi, everyone, and welcome to Critical Path Institute's Rare Orphan and Pediatric Disease Programs webinar series. My name is Dominique Cruz, and I'm a Senior Project Manager with the Rare Disease Cures Accelerator Data and Analytics Platform, or RDC-ADAP. RDC-ADAP provides a standardized and centralized infrastructure to support and speed up rare disease characterization with the goal of accelerating therapy development for rare diseases. It's my pleasure to welcome everyone to today's webinar, ACE inhibitors as a cardioprotective treatment in dystrophinopathies. Before we begin, I'd like to go over a few housekeeping items. If you have any questions throughout the presentation, please place them in the Q&A chat box. The chat function is disabled for all participants just to make sure that we don't miss any questions that pop up, and all participant lines are muted so we can reduce background noise. We are recording this presentation and it will be available after the webinar finishes for on-demand viewing, and we also have our contact information if there are any other questions or concerns that come up throughout the presentation. And with that, I'd like to introduce our first presenter. His name is Dr. Karim Wabi. Dr. Karim Wabi is a professor of cardiology at the University of Paris, France. His expertise lies in the clinical management of patients with cardiomyopathies, with a particular focus on neuromuscular diseases. We are so pleased to have him speaking with us today. Dr. Wabi, I will hand it over to you.
Thank you very much. Let's start by sharing my screen. Okay, can you see my screen? The presentation is in full screen? Okay.
No, it isn't.
No, it isn't? Okay, so it was working a couple of minutes ago, so
Technology.
retry.
It's gone now.
Okay, fine. Okay, so hello everyone. And, first of all, thank you very much for the invitation. I'm really happy to give this talk and be part of this discussion, which brings together so many people from US, Europe, and perhaps beyond, all with the shared goal of improving the future for individuals living with dystrophinopathies. I think we all have high hopes for innovative therapies, especially for treating the heart, but I believe there's still an important place for conventional treatments, which have already provided clear benefits in recent years. And that's why I'd like to show you today, using the example of ACE inhibitors, which is a field our team has been very committed to over the past years. So a few words on dystrophinopathy, cardiomyopathies, which have a quite specific pattern. Is on one hand myocardial involvement, with the progressive development of fibrosis, initially in the inferolateral wall of the left ventricle, and then it gets widespread and leads to the development of dilated cardiomyopathy with a reduced contractility of the cardiac muscle. And at some point, it can lead to heart failure. And heart failure can obviously be a very severe manifestation in DMD and in dystrophinopathy in general. Unfortunately, this is still one of the most common causes of death. On the other hand, some patients can have electrical abnormalities with either conduction defects or ventricular or supraventricular arrhythmias. And sometimes, unfortunately, some patients die suddenly, mainly due to ventricular tachyarrhythmias. It's far less common than severe heart failure, but this is a big issue as well. And sometimes supraventricular tachyarrhythmias can be complicated by stroke. Some patients can also present with myocarditis, spontaneous myocarditis following a viral infection, or sometimes after innovative therapies such as gene therapy. This can be a specific complication of this kind of treatments. Sinus tachycardia is also extremely common. Most patients with Duchenne have their heart beating fast, and this is probably related to autonomous system dysfunction. So the prevalence of those abnormalities increase progressively with age, especially in Duchenne muscular dystrophy. And we know from all natural history studies before the area of prophylactic treatment that diabetic cardiomyopathy is not so common before the age of 10. It can happen, but it's relatively rare. But after the age of 10, its prevalence increases progressively. And the majority of adults have evidence of diabetic cardiomyopathy, myocardial fibrosis, and cardiac dysfunction. Before the development of dilated cardiomyopathy, we can show evidence of myocardial fibrosis, especially with cardiac MRI assessments. And cardiac fibrosis can be present even before the age of 10 years, generally between the age of 8 and 10 years. And patients with myocardial fibrosis diagnosed on cardiac MRI are at higher risk to further develop dilated cardiomyopathy and heart failure. There's a continuum in the risk for myocardial complications between patients with Duchenne, Becker, and female carriers. Patients with Duchenne have obviously the highest risk. You can see here the incidence of dilated cardiomyopathy over lifespan in patients with Duchenne. And you can see that many patients with Becker can also develop DCM, but it's less common and generally it occurs later. But it remains also in patients with Becker muscular dystrophy, unfortunately, one of the most common causes of death. Female carriers have a risk over lifespan probably between 5 and 10%. And in some cases, cardiac involvement can be extremely severe and requiring heart transplantation. So myocardial abnormalities develop progressively, and progressively we see the ejection fraction decline, at least in some patients. The fibrosis burden increase. And the major question is, at what stage is it relevant to start treatments when there's evidence of myocardial involvement or earlier in order to prevent its development? For that, we have a number of medications. And the first medication which has been used in Duchenne muscular dystrophy and in dystrophinopathies in general have been the ACE inhibitors. ACE inhibitors represent the most ancient and the first treatment which has been used for heart failure in the general population, in patients who had heart failure with symptoms and evidence of reduced cardiac contractility. ACE inhibitors, they basically inhibit the conversion of angiotensin 1 to angiotensin 2, another hormone, which has several deleterious effects. So ACE inhibitors can positively impact the whole pathophysiological process of heart failure, which is really complex. Heart failure is also a kind of neurohormonal condition, and ACE inhibitors can inhibit several pathological processes at different levels, it reduces blood pressure, and especially in cardiomyopathies, it prevents the development of myocardial fibrosis. So there's an extensive literature in the general population showing that this treatment is highly efficient in patients with heart failure to prolong survival and to prevent progression of heart failure and the development of severe heart failure symptoms. I think almost of all studies which have been conducted so far, mainly randomized trials with many, many patients, have proven that this treatment is highly efficient and relatively well tolerated. Excuse me. In Duchenne muscular dystrophy, ACE inhibitors, it has been the first treatment has been used prophylactically in a different indication, not like in the general population as a curative treatment in patients with symptoms and cardiac dysfunction, but prophylactically before the development of diabetic cardiomyopathy. And I think this concept was a bit revolutionary. Duchenne muscular dystrophy is probably the first condition for which it had been shown that it could be useful to use heart failure medications early, even before the occurrence of heart failure. Excuse me. The first study showing that has been conducted 20 years ago in kids who had on average 10 years, had a preserved ejection fraction, and 57 kids in this study had been conducted initially in France, have been randomized between perindopril or placebo. Excuse me. I'm really sorry. So there has been a randomization between perindopril and placebo. And the group treated with perindopril at 5 years had a lower likelihood to develop diabetic cardiomyopathy at that stage, with a lower proportion of patients who had a low ejection fraction. And when follow-up has been prolonged, this was an open label extension, which means that all patients have been treated with ACE inhibitors in the two groups later on. The group treated with perindopril had a prolonged survival, reduced all-cause mortality, mainly because there was a far lower risk for patients to develop severe heart failure. There's also a number of preclinical studies in Duchenne muscular dystrophy, mainly conducted in the MDX mouse, showing that using ACE inhibitors early reduces the risk to develop fibrosis, especially in mice treated with glucocorticoids. And thereafter, after the first publication of the randomized trial 20 years ago, a number of other studies have been conducted, some randomized trials, some analysis of observational data registries, and almost all of them showed the beneficial effect of ACE inhibitors and a good safety profile. Quite recently, we analyzed data from our French registry, which included at that moment 700 patients. And we estimated in a real-life setting the impact of the prophylactic usage of ACE inhibitors. We compared patients treated prophylactically versus those who had not been treated prophylactically. Our statistician did hard work to try to take into account all potential confounders. And in this analysis, we found pretty much the same thing as in the initial randomized trial, which is improved overall survival, mainly because patients treated prophylactically had far less severe heart failure. And importantly, the amount of benefit was the same in patients treated with glucocorticoids and others. And also, in a real-life setting, no patients developed life-threatening events following the initiation of the treatment, and the rate of discontinuation of the treatment for side adverse events was extremely low. So based on this whole literature, all recommendations from experts have suggested that DMD patients should systematically be treated by the age of 10 years. You can read that in all those documents and others. But the problem is that when you analyze registry data in the US and Europe, you can see that many patients are still not treated prophylactically. Many patients probably who are not seen in tertiary centers, even sometimes when there's evidence of myocardial involvement, and it remains a huge problem, the dissemination of those recommendations. And one major problem is that all those recommendations have been published, have been drafted by neuromuscular experts or cardiologists, experts in the field of neuromuscular diseases. But when you take a look at the very general guidelines in the general population for the usage of heart failure medications, you do not have a specific indication for patients with neuromuscular disease. And for that reason, many practitioners do not use treatments, heart failure medications properly. So initially, the validation was for an initiation at the age of 10 years. But we have seen thereafter many colleagues worldwide using ACE inhibitors even earlier, mainly because we know that patients can have fibrosis at the age, between the age of 8 and 10 years. And we know that ACE inhibitors are good treatments to prevent the progression of myocardial fibrosis. So very similarly, in Becker muscular dystrophy, ACE inhibitors are also beneficial to limit the progression of myocardial dysfunction, and we have shown showed that in the analysis of our registry, including 180 patients with Becker muscular dystrophy. Patients treated early had a low risk to develop severe heart failure and a low risk to have progression of their myocardial dysfunction. So obviously, ACE inhibitors are highly beneficial in patients with dystrophinopathies. This has been mainly shown in Duchenne muscular dystrophy. And beyond that benefit, I think the strategy based on using prophylactically this treatment has been very important because it paved the way for more general approaches using other heart failure medications. Because in the general population, in patients with heart failure, there's currently a recommendation to use a combination of drugs, and several studies have shown that the more drugs you use at higher doses, the more efficient you are to prevent the progression of the disease. And there are currently 4 categories of treatments which are currently recommended for any patient with heart failure in the general population. You have the family of ACE inhibitors and Entresto, you have beta blockers, you have MRAs such as the eplerenone, and you have SGLT2 inhibitors. And there has been a number of the past years research programs which have been developed, preclinical and clinical, to determine if those medications used in the general population may be helpful in DMD as well as prophylactic treatments. For example, for beta blockers, there has been 2 studies, 2 randomized trials conducted in Germany and in the UK, unfortunately negative studies, also because there was probably a lack of statistical power because it has been extremely difficult to include a sufficient number of patients in those studies. We are currently in the process of analyzing the data of a trial conducted in France as well. For MRAs, you have eplerenone, for which the group of Linda Cribe nicely showed in this publication in Lancet Neurology that in boys with Duchenne muscular dystrophy who have evidence of myocardial fibrosis on MRI, that eplerenone reduces significantly the progression of contractility abnormalities. And there are a number of other studies, preclinical or clinical, assessing the potential effect of ACE inhibitors and of other treatments in DMD. So as a conclusion, I would like to say that ACE inhibitors represent the first-line therapy for heart failure in the general population, that they are highly beneficial and they have an excellent safety profile. There are millions of patients treated worldwide with ACE inhibitors. And in Duchenne muscular dystrophy, ACE inhibitors play a major role in preventing heart failure and improving survival, has been shown in randomized trials, in observational studies, very consistently from one study to another. It's not enough, but it can improve things significantly. And in the end, there will be in the future many discussions and studies to conduct to validate the most relevant strategy for the prevention of sudden death of heart failure in DMD, especially to determine what would be the optimal age of initiation, 10 years, 8 years, perhaps even earlier. Some practitioners even discuss starting ACE inhibitors at diagnosis, at genetic diagnosis. And also it will be important to determine what would be the most effective combination of heart failure therapies among the 4 or 5 we have currently available, at what age. So I think it would be hardly determined with randomized trials, but we will have to analyze probably larger history to estimate the impact of all those treatments in a real life setting. Thank you for your attention.
Thanks, Dr. Wabi, for that informative presentation. We'll now move into our Q&A session led by Dr. Paige Martin. Dr. Paige Martin is the Associate Director for CPAT's Duchenne Regulatory Science Consortium with over 10 years of experience in advancing drug development for rare neurodegenerative and neuromuscular diseases. And with that, I'll hand it over to Paige.
Thank you, Dom, and thank you, Dr. Wabi. I will now introduce our very talented and very experienced Q&A panel. I'm going to go through a quick bio for each of these participants. I had to significantly abbreviate these because if I actually read all of their accomplishments, we would be here all day long. All right, to start, we are very excited to have Colin Worth, who is a proud Virginian. And in addition to his work in IT and marketing, Colin is an advocate for the rare disease community. He currently serves as president of the PPMD Adult Advisory Committee and is working to integrate the perspective of adults with Duchenne muscular dystrophy in drug development and access programs. We also have Dr. John Soslow, who is a professor of pediatrics and director of clinical research in pediatric cardiology at Vanderbilt University Medical Center. He specializes in cardiac imaging and research on Duchenne muscular dystrophy cardiomyopathy. We also have Dr. Inés Macias Perez, who leads product development at Cumberland Pharmaceuticals, specializing in innovative prescription products and providing regulatory and scientific guidance, really from concept to commercialization. Most recently, Cumberland has worked on the phase 2 FIGHT DMD trial, specifically targeting DMD-related heart disease. So thank you for being here. We also have Pat Furlong, who is the founding president and CEO of Parent Project Muscular Dystrophy, also known as PPMD, and is dedicated to ending Duchenne muscular dystrophy through research, advocacy, and education. Pat is also a co-founder of the Duchenne Regulatory Science Consortium here at the Critical Path Institute, and is a great supporter along with our research. And finally, we have Filippo Bucella, who is the founder of Parent Project Italy. He's also a pharmacist and a musician. He's driven by his son's Duchenne diagnosis to improve treatment and quality of life, also through research, education, and advocacy. All right, so thank you all for being here. And feel free, everyone, to put questions in the Q&A, and we will address those as they come up. But to start, I will move this over to Filippo. A number of us had really a great opportunity to meet together in Rome just a few weeks ago to work together with a number of the cardiac clinicians with a cardiopulmonary workshop. Would you be able to do a real quick recap of what that was? And I think that was really an extension of what Dr. Wabi had said, having those discussions around really what are the next steps? Are we looking at when to treat these patients, how early to see them? And I think a lot of really good discussions happen there. Filippo?
Yeah, thank you. Almost 2 weeks ago, Parent Project USA and Parent Project Italia organized a meeting called Cardiopulmonary Consensus in Duchenne and Becker. And we spent 3 wonderful days in Rome with about 15 specialists from the United States, Italy, France, really involved in the cardiac and respiratory management of patients with Duchenne and Becker muscular dystrophy, and also female carriers. So the participants included also 2 representatives from CPAT. I don't know if you heard about CPAT, but together with other cardiologists, respiratory specialists, neurologists, and neuropsychiatrists. There was also a physical therapist, and obviously representatives from Parent Project Italy and Parent Project US. And there were also 2 science writers, because the meeting was indeed a really good opportunity to compare practices adopted in different countries, highlighting strengths and difference in methods of clinical management of patients. But the main goals were to strengthen international collaboration and contribute to development of clearly updated global guidelines. So the first day, we summarized the main previous workshops organized in past years as a collaborative effort between Parent Project Italy and PP USA. And Eugenio Mercuri presented the impact on new therapies on Duchenne, which was the starting point for the meeting proceedings. On the second day, the participants were divided in 2 groups, respiratory and cardiac, and each group session was followed by an open discussion how to improve patient care. This was useful to align expert opinions and synthesize the best practices. On the third day, the groups met to present the main conclusion, recommendation that emerged from the discussion on the 2 sessions. So the groups mainly exchanged their ideas. It was clear that a multidisciplinary approach is important, as Dr. Wabi said, especially for complex topics such as VAD, transplantation, use of the defibrillator, and the implantation of the defibrillators. So there were also interesting discussions about sleep management and the care of female carriers. Some themes were obviously agreed upon by all the next step will be to publish the recommendations to make sure that they will be available quickly and easy. It was clear that implementing these changes in real life will take a lot of time, but it is essential to move quickly in this direction. When there was no consensus, the importance of continuing to network and to collaborate with other colleagues became clearer. It was also said that longitudinal data is very important to understand changes over time. And it was underlined many times that data needs to be shared between centers to make scientific evidence stronger. Another important point was that recommendations should be clear and easy to understand. They should list the pros and cons of each choice so patients and caregivers can make informed decisions. Recommendations should consider the challenges and limitations of centers that don't have multidisciplinary team. A great work needs to be done regarding the specific needs of patients with cognitive delay or autism spectrum disorders. One of the cardiologists said a very important thing: we came here to change outcomes, and the resulting guidelines will have a global impact. At the end of the meeting, specific suggestions were made about which journals should publish the results to make them as visible as possible. And once the guidelines will be published, Parent Project will translate the information into an easy language good for families, and also in other languages like Italian and probably many others. So I feel that was a very good meeting, and I hope we can have many more than other meetings like that.
I think that was a great meeting, and I'm excited to see the consensus come out. I think the last major consensus was published in 2018. So it will be good to update that, especially with, as you said, the amount of data that's been gathered and captured since then. But continuing to gather and capture that data is really key. So I think one point that we had also discussed at that meeting was really in the importance of early clinical visits for the cardiologists with the young boys with Duchenne, but not only the Duchenne boys, their whole families, because as Dr. Wabi had pointed out, this isn't just an issue for Duchenne boys, but also Becker and then female carriers. John, would you be able to kind of touch on the importance of early clinical visits, but also on the importance of imaging these boys, as well as their sisters and their mothers, to assess the condition over time and start to understand really what this disease progression looks like?
Yeah, absolutely. And thanks for inviting me to speak. We had a lot of discussions at the cardiorespiratory meeting about timing of evaluations and how frequently patients should be evaluated, how frequently their family members should be evaluated. And I think, there are a lot of things that really pushed us towards, from a cardiology perspective, feeling like we should be seeing these patients early and then relatively frequently to make sure that we're not missing anything. One of the biggest points really is that we know that delayed enhancement starts younger than 10, and Kareem pointed this out in his talk. And we see about 15% of patients will have delayed enhancement under 10 years of age, and in fact, a lot of them around 8 years of age. So it's pretty early, and then we see some patients with even younger manifestations. The reason we don't see many, partially, is because we're not doing a lot of MRIs on those patients, because it is quite difficult to get MRIs in younger and younger patients. And so it's really important to understand that this disease starts earlier than what we're detecting. And so that's a big part of it. The other thing that came up in the meeting, which I think was eye-opening for a lot of us, was just the number of people who'd seen significant heart failure and dysfunction in really young patients with DMD. And it wasn't meant to be like a scary thing and to make anybody afraid of this, but there were patients who are manifesting heart failure symptoms at much younger ages than we typically expect. And so it really brought home the idea that we need to be seeing these patients early to make sure that there's nothing abnormal, and that we really need to be seeing them probably every year or every 1 to 2 years. There was a lot of discussion about that frequency. And I think most cardiologists really felt that yearly was probably the way to go, just because it gives cardiologists the opportunity, as you pointed out, Paige, to continue to develop that relationship, to continue to see those hearts and make sure that there is not any unexpected progression when we're looking at echocardiograms, and to continue to follow family members and make sure that everyone else is getting in to get the therapy they need. So that can be sisters if they have it, that can be siblings, and that can be parents who are carriers. And so I think it's really just the entire family, and really making sure that everybody is getting that education, getting that follow-up, and getting the care that they need.
Yeah, and I think the other thing that we've started to see that we can leverage is taking that clinical data and starting to make informed decisions, right? We can take those images over time, that longitudinal images, to understand that disease progression, which then can help the next stage of development for drugs. Which brings me to Inez. So Inez, as I had said, is the product development at Cumberland, which recently you had the Fight DMD phase 2 trial, which I know John was actually part of to help with. So can you discuss that? While ACE inhibitors currently are really foundational, really, what are we looking at for these new drugs for development? And then also, I think, speaking to kind of that age range, but not just the age ranging, but the staging that you had to do in that trial.
Great question. Thank you for the opportunity to speak on this. Because as the speakers and the panelists have already mentioned, it is a lot of options, right, that they have. There's ACE inhibitors, there's ARBs, there's beta blockers, steroid use, all can impact the heart. And so far with our drug, ephedraban, as a thromboxane receptor antagonist that can also prevent inflammation and fibrosis and is a potent vasoconstrictor, it can block that vasoconstriction of the thromboxane receptor. So we wanted to be very careful and selective about the patients, but we also wanted to be inclusive because as the DMD specific FDA approved, whether it be traditional or conditional or fully approved medications are out there, oftentimes they're very focused on skeletal muscle dysfunction and not, there's very limited data on what the impact is on the heart. So as you see, there's a lot of confounders out there. And so to be inclusive, but yet be controlling for all those major confounding factors, we needed to be careful in our design of our clinical trial to address all these unique challenges that come along with DMD-associated cardiomyopathy. So the way we did this as a team, we did decide to permit all cardiac meds and allow clinical care to decide on the dose and which regimen, and the families, of course, have a big part in that at the front end. And then we stratified based on that. So if they were on an exon skipping drug or a steroid, we made sure to balance at the front end with block randomization, patients on placebo and on an intervention, ephedraban, to make sure that we had that balanced at the front end. The cardiac meds just had to be stable for 3 months prior to joining. And then for some of the other cardiac meds, they needed to have a longer window. And then, of course, we were following them by cardiac MRI. That is the most sensitive way. And with that comes the age limitation or minimum age of 7 years. I know that that could be very challenging, without sedation, but with good coaching, John and Larry Markham all decided that they felt like 7 years or greater was a good cutoff, that with proper coaching we could. But, that's also limited because with a cardioprotective medication, you'd want to start it as early as possible. But without the cardiac MRI, you couldn't really judge whether the drug was working on that younger age group. So we decided to also, of course, use natural history data to help supplement our placebo group. Because even with proper stratification at the front end, we still ended up with the high dose ephedraban group with heavily medicated compared to placebo. So it was really nice to have John's natural history cardiac MRI specific data, because some natural history registry studies don't collect CMRs. We have a program in Friedreich's ataxia, which that was the case. They have a lot of robust natural history data, but no cardiac MRI. So we were really, really blessed to have that and very favorable size and robust data to be able to select from propensity score matched patients to our high dose. And that helped us boost the placebo arm 2 to 1 and able to see the impact of ephedraban and in a positive way to help preserve cardiac function.
Yeah, I think that's a really important aspect to think about is when we're collecting this clinical data, or if you're part of a natural history study, that's really important data that's going to go on to support how to design these clinical trials, but not only design them, but also sometimes supplement on the back end to support whether or not a therapeutic has been effective. So all of that data that's been gathered, it's really key to moving the needle forward. So thank you so much. Okay, so Colin, I would love to hear your perspective, really understanding how important it is to the patients as we're advancing this cardiac focused research together. Really, what do these improvements in cardiac care mean? And most recently, being able to see these studies come together, and what's that been like?
Yeah, so thank you for allowing me to be here today. I really appreciate it. And yeah, great to be with this panel of experts. So just start by introducing myself. So I'm actually 30-year-old living with Duchenne. So that the group Parent Project Adult Advisory Committee with is a group of 60 adults with Duchenne and Becker. So we work to be a resource to the community, whether it be clinicians, researchers, families, and others. So yeah, so my experience, yeah, I think it's really important. I'm a big proponent of participating in research. Realize not only can it be beneficial to myself, but beneficial to others. That also, I think Parent Project has done a lot, and credit to Pat Furlong to improve the care guidelines in Duchenne, and really has greatly expanded the lifespan of Duchenne. So I think it's certainly important, as those with Duchenne are living longer lives, that we are protecting the durability of the heart and lungs. So certainly as older patients, we're definitely looking for any trials we can get. And I really applaud Cumberland that they've been inclusive of the adults with Duchenne in their trial. And I've actually will disclose I've been in the trial and just had my year follow up on open label and actually saw improvement in function. So I was really excited to see that. And also I've been on, so I started at age 14, I started on ACE inhibitor and Alpro. I've been on that since then. And started on four year, so at 18, I started mineral corticoid receptor antagonist, spironolactone, and really, yeah, I still have normal heart function at 30. So I'm really, yeah, grateful. All these guidelines have certainly been beneficial to me, and yeah, a lot of my friends in the adult advisory committee. So yeah, but just really grateful, and certainly want to give back to yeah, others, and hope better care for future generations with Duchenne.
Yeah, I think that's a great point, is that, it's the pioneers like yourself, Colin, that are really pushing forward the needle at your own expense, really for the next generation. And that's huge. And everyone is oh so grateful for that. So we will also touch on this with Pat. As Filippo said, we probably all wouldn't be here without Pat. Pat is the co-founder of PPMD, and I would say, at least for everyone I know here, has connected us together. I think that PPMD does a lot of advocating for the patients and the families, especially from an educational standpoint. Pat, can you kind of really touch on, what programs you had for the cardiac aspect, in making sure that families are aware of this aspect of Duchenne and other dystrophinopathies, in addition to, the skeletal muscle?
Sure. Thank you, Paige, and thank you for including me on the webinar. I think from the time Filippo and I started, we asked that question. The heart is a muscle too, and we used to say that all the time, right? And then the second question that we ask, because as parents, when our children, and Colin, I'm sorry that you're 30 and I'm going to still call you our children, because that's what parents do. So I apologize. We focus, especially in that early days of diagnosis, on how can we preserve ambulation, right? And that seems to be such a focus that I think Filippo and I have talked often about the idea that, so theoretically, as therapies are developed and people are walking longer and longer into adulthood, is the heart at risk now, right? If we're not really addressing heart disease. So that really started the discussion about, so could we use tools that are available, the ACE inhibitors that you mentioned, or the ARBs, and does that make a difference, and how will we know? So we were really pushing for that. And Filippo and I, who've worked together for, I don't know, many, many years, we thought about putting on and thinking about, could we find some cardiologists? Would they be interested? And we first linked up with the Action Learning Network, which is a very broad group of physicians looking at cardiac failure in pediatrics. And then when we talked about this, they carved out of that pediatric heart failure in Duchenne as a specific sort of different failure than perhaps in other circumstances. So that led to several meetings about how do you treat the heart through the lifespan? Can we start early? And as parents, we're always very anxious about prevention because, it seems to us when we see skeletal muscle deterioration, you really have to start early and try to prevent that, right? And the same goes for the heart. So we've had I think, Filippo, this is our 4th cardiac meeting that we've had in a row. We've also asked, as this progression occurs and as these cardiac MRIs are read out, are there abnormalities in rhythm? So is that some of that fibrosis over the electrical system, if you will, of the heart and causing abnormalities? And I know some of the boys over time, my own included, would say, I feel funny in my chest and I don't know what that was and not here to diagnose it. But then you wonder, are there abnormal rhythms and how do we know? And so this cardiac MRI and looking at loop recorders and other things so that we're looking at these hearts over time. And so that heart does withstand that additional function as new therapies. And so we were thrilled to see Cumberland come on, thrilled to see this attention. I think John Soslow at Vanderbilt has probably one of the most robust data sets that we've ever seen in Duchenne muscular dystrophy. And we can't say enough for data sharing. So I think our commitment is, the heart is a muscle too. We've got to pay attention to it from diagnosis, but also that we have to recognize this is a family disease, and females may be at risk to be carriers. So we have to look at the heart and think about, even though when my sons were diagnosed and we were thinking about my daughters, the thought was they're going to be asymptomatic. And I think what we've learned over time, again, by data and by sharing the data, that in fact we can see heart disease in these carriers, sometimes very severe in very young ages. So this emphasis on the heart to protect it throughout a lifespan is really incredible. I think the fact that companies like Cumberland are saying, we're going to make sure that we understand how to design a trial so that we really do understand the protective factors of this particular drug. So we're thrilled for that, thrilled to include adults because Colin at 30 has a good heart. We want that to last 50, 60, 70, right? We want him to become an old guy here. So I think this emphasis on heart disease, and I can't say enough for critical path, to be able to get data sets in here and to analyze them and be able to come up with decisions about or some ideas about here's what we learned through the data that we have. I think first of all, demonstrates the need for data sharing. And second of all, when you have several data sets that you're able to put together robust data, then we're able to better understand disease progression. So I think it's about a family for me, right? It's about when you get a diagnosis and you feel pretty alone, and then you find really smart people around you that are committed to change this world. And so I can't say enough for Dr. Soslow and the action group. Of course, my friend Filippo Collingworth, who is with the PAC, who, when my sons were here, the adults didn't give us direction, but now they're giving us direction, which is a lovely thing to see, and to the companies and to Critical Path. It's been an amazing journey with Critical Path, and I think we're now seeing the light of treating early. And I guess if my son was diagnosed today, I'd probably want to start an ACE or an ARB right there, which may be a little early, but I think prevention is the key. So I can't thank you enough for including me in the webinar today.
Yeah, I think one of the things that was said really during the workshop that perked my ears, that we often say boys with Duchenne, but someone had said, I think Filippo, you had said, I am a father of a young man with Duchenne. And I said, wow, we're really moving the needle from boys with Duchenne to men with Duchenne. And that's great. And with that, we're thinking about these next stages of the therapy. And really an important part of that is the cardiac phenotype. So it's really great to have everyone thinking about that and moving that along. Okay. So we do have time for questions, maybe 1 or 2 more questions from the audience. So I do have a question from the audience, and I'm probably going to give this one to Dr. Wabi and Dr. Soslow, because I am not a cardiologist. It says, can we expect reduction in fibrosis while on Ernesto, which, if I understand, Ernesto is an ARNI inhibitor? And if you can't answer that, that's great. And if not, then we can move that.
I'm happy to sort of weigh in on that. I'll say that we don't have a lot of DMD specific data in Entresto. And so there's been one retrospective study that showed some improvement in function, which is encouraging. A lot of us have been using it. I think the general thought, I guess I don't want to overstate this, but the way I think about it is that we're probably not going to see improvement in fibrosis for the most part. And that's because once we see fibrosis, we really think of that as an irreversible thing. We can see improvement in late gadolinium enhancement, on the other hand, because that can also pick up edema and other abnormalities in the myocardium. And so it's possible to see some improvement in that. We certainly can see improvement in function given the way Entresto works, just because it's a pretty significant afterload reducer, and it has multiple ways of sort of, as Kareem mentioned, regulating or improving cardiac function and remodeling of the heart. And so the short answer is probably not reduction in fibrosis, but we certainly think it will lead to improvements in the heart.
Thank you so much. Okay. So I don't have any other questions right now from the audience, but I do have another question for myself. So I've been thinking a lot again about, getting all this data together, especially the cardiac imaging and other things like the rhythm monitoring data, in order to really start to think about that disease progression of the Duchenne and the dystrophinopathy cardiomyopathies. So one of the challenges, and as maybe you can touch on this, is that the traditional classification systems for cardiomyopathy really don't fit a patient with Duchenne, because a lot of it is about the movement that these patients may not have. So we're really going to need to think about a different framework for classifying these cardiomyopathies. And maybe John, you can speak to this. Really, how do you think that integrating this data and bringing together cardiac imaging, but other data like biomarkers could really help to shape a new classification system specifically for cardiomyopathy in dystrophinopathies? It's a lot of opathies.
No, you're right. The current adult heart disease classification, it doesn't work in for DMD specific, right? Because the pathophysiology in DMD is very unique. So it's really incorporating like the cardiac MRI parameters, some DMD specific LVEF thresholds, disease specific markers that, are not, adult cardiac markers that are standards. Those were also, requested of us by the FDA. And so there's a lot of education that needs to go about, sharing with them that this isn't adult heart failure and that the traditional cardiac biomarkers, have been shown that they don't work in DMD. So yeah, I think it's really important to establish a DMD specific classification and incorporate CMR data and as well some unique thresholds that we learned from the natural history studies.
Well, I think if you take a look at the most recent recommendations from cardiomyopathy expert groups, for example, we had recommendations in Europe published last year. It has been acknowledged that the historical definition of dilated cardiomyopathy, left ventricle which is dilated plus reduced ejection fraction, should probably not be used, and that we should rather considering the fact that a patient at risk develops at some point myocardial disease, and myocardial disease can present initially only at fibrosis. So I think you can now, at least based on those most recent guidelines, mention that if you carry a mutation and you're at risk of having a myocardial disease and you have evidence of myocardial involvement, fibrosis or mild contractility abnormalities, then you can be considered as a patient with dilated cardiomyopathy. The whole definitions have changed a lot over the past 20, 30 years. And the most recent one acknowledged that we should see things, as you mentioned, consider patients with only early signs of the disease as having the disease.
Mm-hmm. I think someone had said at the workshop, maybe it was Frank, John, that said, patients with Duchenne have cardiac disease from the beginning, right? Because this is a genetic disease. And so the gene is changed. And so in those tissues, that's from the beginning. And so that's a little bit different and really changing the way that classification system can be used. I think we've kind of touched on this a little bit, but I'd really like to drive home because this was, again, another thing that really was, I think, brought forward to me, again, in this workshop was that, you know, it's not just these young men with Duchenne or Becker's that is going to be affected, but it is also the mothers and the sisters who are carriers, and even women who are carriers that don't have, you know, brothers or sons that have Duchenne. Really what data has been gathered on these carriers and what really should be gathered next to start to better understand how to better provide for this population that's probably underserved for this aspect.
Yeah, I think that's a great question. As a pediatric cardiologist who has a lot of patients and parents that tend to ask me questions, I think the biggest thing from our standpoint is really trying to either get a clinic up and running, which we finally have established at Vanderbilt, and or get the word out to adult cardiologists. They can't just do an echo and say you're fine and you don't ever have to come back again, which is really what most of our patients have experienced up to this point. And so it's both education and really getting the experts to see these patients, and really the latter I think is the most important. So getting these patients to the right people that will know that they need to be followed long term is the most important thing from a clinical standpoint. From a research standpoint, you know, Khan and Mei Ling and Teresa Wang have done a lot of really good work trying to figure out what the progression of disease is. And as Kareem pointed out, it's about 10%. But then there are other people who have symptoms, and I think it's really important to understand that spectrum and to really understand what the progression of disease is and try to get a sense of who's at the highest risk, so we know who to see more often and who we might be able to see less often. And I think that's the next step in my mind for research in carriers. I'd love to hear what Kareem and Pat and Filippo think.
Well, I think, you know, I always make some kind of bold statement. I think carriers need to be cared for. And I think often they are dismissed. And whether or if we see cardiac implications early on, I think that there are many other emotional issues that come into carriers, and sometimes, especially the primary caregiver, often sort of just dismisses their symptoms because of the care that's required for the child that they have. So I think, you know, again, seeing in the absence of any cardiac effects, seeing carriers once a year to just check in and make sure things are going, maybe even offer them some suggestions about taking time for themselves, an exercise routine, taking good care of themselves, because the moms that I know often, as I say, dismiss their own personal care in light of their family's needs. So I do think there's something there, and I think we have to learn more about it. And I'll just throw this out there, you know, I think there's much more to learn about carriers than we know now. So we really now concentrate on their hearts, but I know just in my experience talking to carriers, many of them have had a series of miscarriages before that they've had, or before or after they've had a live birth. Some of them, you know, can't exercise. And we did a study with Nationwide Children's and found that, you know, on stress EKGs that they really did struggle with exercise. So I think there's more to carriers than we know now. And I think we need to see them routinely and just make sure that we can get a good natural history on carriers, even though we predict that it is fewer 10% or plus or minus with cardiac disease. I think there's other things happening that we need to pay attention to.
Yeah, I think that there's always more to learn. And especially, again, those carriers who are carriers probably, and they don't even know that they're a carrier because they have no familial history yet until they've, you know, had a child. So yeah, it's always important to gather that data in order to better understand the disease progression so that we can then start to make really data-informed decisions, both clinically and in the research aspect. So I'd like to thank all of our panelists for taking the time out of their very, very busy lives to really bring to light, as Filippo said, what's really at the heart of our research here, which is the heart in Duchenne muscular dystrophy, Becker, and those female carriers. So thank you so much, Kareem, for a wonderful talk. And I'd like to say thank you to everyone.
Thank you.
You.
And with that, we'd like to invite you guys to our webinar that is next month on May 22nd. Look out in your email and LinkedIn for the registration details. And we will follow up with the link to this this awesome webinar after we finish. So thanks everyone again, and hope everyone has a great rest of their day.